So welcome everybody to the Cholangiocarcinoma Conference 2021 on our 15th anniversary. And it's a great pleasure to be here and to be co-chairing this conference with Funda Merritt Bernstein, my colleague from MD Anderson. I'm John Bridgewater. I work at the University of London, University College London Cancer Institute in London. And we've had great fun putting together this year's meeting, a virtual meeting. What a shame. Every year I look forward to coming to this gorgeous place with mountains and the sheer natural beauty. Quite frankly, I wish I were in Salt Lake City. But as it is, we're here, and my job in this first session is to give you a bit of an experience about how the COVID pandemic has affected the management of cholangiocarcinoma, the hospital services, care of patients like you with cholangiocarcinoma, how I think that's happened. So this is the rather grim slide, and this is just a dump from a regular report that we were getting on a daily basis. This is April 2020 in central London, and this is pretty grim. So if you look at the center bottom graph here, you can see the dark green bars gradually rising over the course of 10 days, from 33 to 58 patients ventilated in our hospital. Number over here, you've got the number of deaths from positive COVID patients in the last 24 hours. This was a grim time. This was an awful time. We had no idea whether we were going to emerge out of this, and the news just got worse and worse. Of course, we have gotten out of it, but this seemed almost unlikely at that time. Just to give you a flavor of what it felt like. Incredible and unusual things happened. So this, one of my favorite images from that dark time last year, is the map of pollution in northeastern China, one of the most polluted places on the planet. And you can see pre-lockdown, it's just a smog city over here, the whole of northeastern China. And during the lockdown, it becomes almost pollution free. And it's estimated that actually during this period in China, the improvement in terms of mortality from asthma and other pollution-related illnesses far outweighed the loss of life from COVID. So that's a slightly dramatic, if controversial statement, but it was such an extraordinary time. The other huge impact, of course, is the economic contraction. And here we have loss of GDP, so that's minus 2, 4, 6, and 8% going that way. The estimate is that there's something at the time was that there's something like a loss of GDP of something like 8%. Transpires it's much more than that, and in fact much more than the depression. This was an estimate in April 2020, and that estimate is changing the whole time, of course. And most of this impact hit the low-skilled workers. Okay, high-skilled workers maintain their well-being. And middle-skilled workers really did particularly badly. So it's not the well-off who are hit by this. It's the middle-skilled people. So on the background of all of this, what happened with cholangiocarcinoma? Well, the initial reports about how cancer patients did with COVID infections varied. This was one of the original reports from China, and this was a bit worrying. suggested that people with cancer deteriorated more rapidly than those without cancer, and that the time to severe events was much more rapid. Slightly more nuanced data came out. This is from the UK, from the Lancet Oncology, and this situation was rather more complex than it seems. So the people who did do badly, if you got COVID, were in fact the hematological malignancies and those with lung cancer, and that's predictable because the hematological malignancies, they're the people who are significantly more myelosuppressed than those given other treatments. Here we are, digestive non-colorectal, and the impact is actually modest. And generally speaking, now it's felt that if you're a cholangiocarcinoma patient on chemotherapy, you don't really do significantly worse if you were unlucky enough to catch COVID. What about the long term? So that's the short term impact. What about the long term impact of COVID on cholangiocarcinoma? We don't really have any figures, but here are some figures for esophageal cancer. So these people used a slightly complicated mathematical model to come to a conclusion here. I'll try and explain that to you as best I can. In the pre-pandemic period, about 18% of patients in the UK presented as emergencies to health bodies. So 18% you wind up in the emergency room with difficulty swallowing, primarily if you're esophageal cancer. In the scenario of cancer services that were shut down, which they were during the first pandemic, you reckoned that the emergency presentation of those people would rise to about 25%. If they were shut down, slightly more, it'd be 26, and so on and so forth. And they calculated through some complicated mathematical model, which I'm sure I won't understand, that there will be between a 5 to 9% increase in mortality of people because these services were shut down. This is a projection. We don't know this is going to be the case. It will be probably years before we're able to fully assess the impact of COVID on health services, and consequently the ability to be able to diagnose cholangiocarcinoma in this through the pandemic. What about day-to-day life? How we managed it? So here are a few things that I think have changed. Here's what happened in the first lockdown, and here's what happened in the second lockdown. And to show that actually it may have taken us slightly by surprise, but I think we've adjusted reasonably well. So with respect to diagnosis, it's clear from this and the previous slide that the diagnosis of cholangiocarcinoma was significantly reduced. This is a combination of services being shut down and actually people being scared to come out. There's so many people who told me they were scared to come out and see the doctor during the worst bit of the COVID pandemic, and that was in lockdown 1. This is actually dramatically different in lockdown 2. I think the penny finally dropped that you can't shut down cancer services. This is going to have long-term impacts. I'm sure it will. And we were told, and to be honest, they stuck to their word, that cancer services, certainly in the UK, would be the last thing to be shut down. And we've had very high levels of activity going down through, in the UK, we've had a second and a third lockdown. Telemedicine. Well, nobody knew how to do it to begin with. Now we are all Zoom experts, and the prospect of having a video conference with a new patient, multiple new patients, and supervising people's patients through the video is now completely standard. And if you said that was, if you were trying to bring that in as a standard non-emergency strategy, it would take you years. This took us a matter of months, and now we will never look back from that, I'm sure. Surgery happened in the first lockdown in clean hubs. So really clean hospitals. People were swabbed 10 times a day. I jest, but a lot. And these hubs have continued active during lockdown 2 and 3. Clinical trials were all stopped during lockdown 1, but they have not been stopped during lockdown 2. Indeed, they're one of the few activities that have been conserved. The one area where things are not so good is research funding. So certainly in Western Europe and the UK, a lot of research funding depends on charity, and charity monies have completely dried up. This shows no sign of getting better in lockdown 2 and 3, and we reckon that research, certainly charity-led research funding in Western Europe, is going to be extremely badly hit for at least 5 years as a result of this. So there's a summary of what's happened. Of course, we will recover. We will recover from all of this. The issue of the diagnosis, the weaknesses in the system were brutally exposed, and I'm sure will be the subject of further investigations to come. There were some positives. Surgeons learned to work in a different way. Telemedicine is great, and the huge benefit of clinical trials is going forward. The impact on research funding we'll have to see, but at the moment that really doesn't look very good for us. Overall, I think we've come out of it looking very well, although the long-term picture we will have to see. And with that, I'm going to pass over to my co-chair, Funda, who's going to give her bit of the introduction. Funda, please. Thank you very much, everybody, for your time and attention.